Good morning, respected judges and this August gathering. I am Dr. Pragya Padacharji, and I will be presenting my paper on Helveston syndrome, patient-tailored management. No financial disclosures. As we all know, Helveston syndrome or the triad exotropia is a rare and intriguing set of strabismic conditions manifesting with dissociated vertical deviation, superior oblique overaction, and A-pattern exotropia. So in this paper, I will be reporting two such rare cases of Helveston syndrome attending our OPD with variable degrees of primary gaze horizontal deviation with good post-operative surgical outcomes. Now, there can be variable permutations of surgical procedures, but choosing one can be extremely challenging. Pertaining to the variable extents of the presentation, the unpredictable outcomes of the surgery, and the multiple surgical procedures that we have to do. But as we know that one key does not fit all locks. Similarly, management of Helveston entails to be individually oriented. It is a prospective study of two patients, both with thoroughly evaluated, and based on the magnitudes of deviation, the procedure of choice was chosen. Post-surgery, both of the cases were followed up at regular intervals. The first case is a 20-year-old female who presented with the chief complaint of outward deviation, both eyes alternatingly since birth. No other positive history except for a positive family history of exotropia in her sister. General examination, slit lamp evaluation, and best corrected visual acuity were normal. Coming to squint evaluation proper, she presents with a compensatory head posture of face turned to the left with chin down. The HCRT showed a large angle primary gaze deviation along with a vertical deviation of 7 degrees. When we performed the cover-uncover test, we saw that there was, on covering the right eye, the left eye comes inwards and downwards with fast retracel of movement. Under cover, the right eye goes upwards and outwards, and on uncovering, it remained the same. Similar findings were seen on the other eye, and on performing the alternate cover test, we saw that both the eyes moved inwards and downwards alternatingly to take off fixation with fast movement of retrace and also associated with fine latent nystagmus. In this slide, we can appreciate the dissociated vertical deviation. The non-fixating eye is upwardly drifted, and it is associated with extorsion and abduction of the deviated eye. When we did the prism cover, we found again a large angle of 80 to 90 prism diopter space in with a vertical deviation of 18 prism diopter space down. Post-occlusion, we saw a very significant difference of 20 prism diopter space in from up gaze to down gaze, thereby telling that it is in fact an A pattern of exotropia. Extraocular movements validated the similar findings of A pattern exotropia along with both eyes superior oblique overaction. To manage this case, both eyes underwent lateral rectus recession along with infraplacement of half width of the muscle, followed by the fade-in operation of the superior rectus. Post-operatively, very good outcome was seen with the correction of the DVD, with collapse of the A pattern, and with reduction of magnitude of superior oblique overaction and horizontal gaze deviation. Now coming to my second case, which is again a similar case of a 24-year-old man presenting with outward deviation of both eyes since birth. No other positive history, general examination, slit lamp evaluation, visual acuity were good. On squint evaluation, he now presents with a compensatory head position of head tilt towards the left-hand side. HCRT showed a large angle primary gaze deviation with a vertical deviation of right eye more than the left eye. Again, cover-uncover test, alternate cover test is similar as the case before. Here we can appreciate the DVT component. On doing the prism cover test, we saw that there was a large angle of 70 to 90 prism diopter space in with a vertical deviation of 20 to the right eye and left eye 18 prism diopter space down. When we did the post-occlusion, we saw a very significant difference of 40 prism diopter space in from up gaze to down gaze, thereby telling that it is a very significant A pattern exotropia, and we can also appreciate the superior oblique overaction in the picture here. To manage this case, left eye lateral rectus resection surgery was done along with both eye superior oblique posterior tenectomy. Here is a small video, but because of paucity, I will be moving ahead. Post-operatively, we saw a correction of DVD, a very good collapse of the A pattern deviation, and also reduction in the magnitude of superior oblique overaction and horizontal gaze. Now, there is no singular dictum for management of Helveston, but based on the magnitudes of deviation, we can make our own algorithm. So like in case 1 and 2, we can see that there has been very good correction of all the components of Helveston syndrome, and noteworthy is the near orthotropia that could be achieved for case 2. Therefore, to conclude, in both the cases of Helveston syndrome following the surgical procedures, very good and optimum outcome has been shown, which was acceptable to the patients and tailored to the management of deviation. With this, I conclude. Thank you very much.
Did you do any superior rectus recession for DVDs after this?
Yes, ma'am. For the first case, superior rectus recession was done, but not for the second case, ma'am.
Okay, okay. And how for, what did you do for superior oblique? What is the surgical
Ma'am, in the
procedure?
first case, we did not really touch for the superior oblique, but in the second case where the superior oblique overaction was very significant, we did superior oblique posterior tenectomy, ma'am.
Yes, ma'am. V pattern total, A pattern total collapsed.
Ma'am?
A pattern after surgical, this thing, it got collapsed.
Ma'am, in the first case, there was residual, but in the second case, we had a very good correction, ma'am.
Okay.
Why the AH? Why was there an abnormal head posture previously?
Ma'am, they actually, because of the different components of Helveston, they had anomalous head posture. In the second case, I can justify it to you because she had a very good superior oblique overaction. He had a very good superior oblique overaction, so the compensatory was to the opposite side. But the first case, she actually had a left deviation more than the right deviation, but still she comes with a left head turn.
And how was the torsion in the first patient, in both patients?
Ma'am, in the
Grading
first...
of the torsion.
Ma'am, great. Ma'am, in first patient was +2. The second patient was +3.
Thank you.
Thank you, ma'am. Thank you, sir.